Thank you so much for this very, or too nice introduction, I would say, but it's all true, of course. I am really happy to be here. It's actually my first time in India, and that's a big mistake. That is the first time. It is a big mistake. I really would love to come back. It's a fantastic country that you live in, and I can only say positive things when I get back. That's it. Okay, I can see that I'm too small for this podium. I need to go. All right, so I was invited to talk to you a little bit about the Danish Hernia database because we have lots of data gathered and have made some contributions to the world of hernia. So I will run through it, the history and our future perspectives also. Let's see here. Yes. First of all, a little bit about my country. It used to be the happiest country in the world. Do you know the World Happiness Index? Have you heard about that? You can Google it, World Happiness Index. Every country in the world is ranged for the inhabitants' happiness. And we used to be number one actually, and have been that for many, many years, but now Finland beat us. Finland, of all places, I don't understand it. But that's how it is. And unfortunately, you can see India is not so happy, but there's room for improvement, as you may say. So why is this so? Why are the Danish people so happy? I think some of the explanation comes from an extremely low crime rate. We have fundamental social security. We get money for doing nothing if that's required. We even get money to go to university. The students get paid to study, which is, you can discuss that, but that's how it is. School is free, healthcare is free, and people have a very good standard of living. We are only 6 million people. You can see it's less than in this beautiful city. So it's a very small place. We have our own language that nobody understands other than us. That's an advantage if we're traveling. That's very nice. We can speak about the other guests and they don't understand anything. And we used to be a big nation. We used to own Sweden, Norway. We still own Greenland, though, so we do have lots of land, but nobody lives up there. It's terrible, too cold. So this is a little bit about the history. Denmark is actually a monarchy. We have a queen. She's sitting there. She's very much loved by all the Danish. And when she dies, this guy will be king. When he dies, this guy will be king. But they don't have any power. But we love them still. And we do have a parliament, prime minister, and so on. So this is the governmental things about Denmark. I come from a hospital in Copenhagen. It's a little bit outside the city center. It's called Herlev. It's difficult to say maybe. It's called Herlev Hospital. And our catchment area covers about 10% of the national population. So we do have many operating theaters, lots of activity. Herlev Hospital is mostly known for its architecture, the use of colors inside. You can see this is the inside of the hospital and a standard bedroom. It looks a little confusing, but it's actually a very nice working environment to go there every day and have all these colors in your retina. So what's also special about Denmark, and in this context, this is quite important because Denmark has gathered more data on its citizens than any other country in the world. We have numerous national registries, so everything is registered, and there's also a downside, of course. You can't hide from these registries, but they know everything about us. This editorial was written some years ago in Science that the entire country is actually a cohort, and we can have some advantages from this also in the database, because from 1968 we had the Central Person Registry, And this is in the middle here. Every citizen has a unique number. You can see this is the birth date, and then some registration number, and the last number, you can see in this case it's an odd number. It means that it's a male, and if it's an even number, then it's a female. And this number is central to all the different registries that we have in the country, and this is the Danish Hernia database. So if a patient gets a hernia repair, we can cross-check the data from all these other things, you know, how much drugs did he get from the pharmacy, how long time was he in hospital, what other diagnosis does he have, has he other diseases, is he married, how many kids, and with whom, and you name it. You know, we know everything about them, and it can be translated into some very interesting scientific data if we want to. This year, the hernia database has 25 years birthday. It was established, the first one in 1998. The initial goals, which are set out by the government, that was to monitor and improve quality. That's the most important thing, to monitor and improve quality. We also need to give feedback to the individual surgeons and hospitals, and to identify trends and outcomes on a national level. So we set out with these overall goals. Then a few years later, the government made it mandatory for the surgeons to register. And this has been a huge difference because they have to register. We don't have to discuss it anymore with the surgeons. They simply have to do it. I don't know what will happen if they don't actually, but they have to do it by law. When we started, about 20% of our repairs were done for a recurrent hernia. We wanted to decrease that. Convalescence was more than 4 weeks. We didn't know anything at that time about chronic pain. Should we use a mesh or not? You know, today it's quite obvious that we would use a mesh, but at that time we did not know that. And the use of local anesthesia for infiltration anesthesia for the hernia repair was very, very rare. So we set out with the aims that we chose ourselves in the database, that we would reduce the reoperation rate by 50%, and we would eliminate techniques with high reoperation rates and reduce the use of regional anesthesia and hopefully increase the use of local anesthesia at that time. I'll show you later what happened with the type of anesthesia. We would also reduce convalescence to 1 week. That's not time in hospitals, that's convalescence from normal activities at home. We wanted to investigate chronic pain and then streamline the different operative techniques. And I can tell you it was fun, because we had many meetings with all the hernia surgeons in the country just to discuss how to do a Liechtenstein repair. I mean, you can't imagine that it was my way, my way, my way. It was not the same. But we succeeded in streamlining it quite okay, I think. So today it's done almost in the same manner throughout the country. We also have to, because it's a national quality database, we have to choose some quality indicators. And for groin hernias, the indicators are presently that reoperation rate within 12 months should be below 1%. Mesh repairs should constitute more than 95%. Ambulatory surgery in more than 85% of cases. And laparoscopy for women in more than 80% of cases. And for ventral hernias, incisional hernia with a mesh should be done in more than 95%, because at that time, before, you know, many cases were done by simple suturing, but that had too many recurrences. So we want to use a mesh, especially in incisional hernias. Postoperative admission in ventral hernias should be below 4 days, and 30 days readmission rates below 15%, reoperation rate below 5%, and mortality below 0.5%. We are almost there for ventral hernias, and we will soon change these indicators to even better. Here you can see the amount of operations that we got. We started the groin hernia database in 1998, and now we have about 350,000 cases. And then in 2007, we actually created a new database with ventral hernias, which has now 70,000 cases. So you can see that when you talk about the Danish Hernia database, it's actually 2 different databases, but run by the same steering committee. if you are more interested, you can of course go to the website and read some more details. I should say that the publication list at the database is not updated, so we are about to do that at the moment, so you cannot see all the publications there yet. So what happens when a patient has a hernia repair? Then the surgeon will immediately after surgery, go to a computer and put in the intraoperative information about the procedure. This is information that is not easily found in other registries or even in the patient files. These are extra information, and it is done immediately after the procedure. It takes maybe 1 minute, maximum 2 minutes, and most surgeons they do that. When we started in '98, it was a simple paper form. As you can see here, it was faxed then to a secretary that put it in the database for the whole country. Then in 2007, we went online with this kind of registration, pop-up and pop-down menus and so on, and we just changed interface recently. If you want to look at the variables that we have in the database at the moment, you can see it in this publication. And the essential thing is that these variables cannot be found in other registries or in the patient files. But you can look at it here, and you are more than welcome to copy-paste it if you want to do that. I know that we have a session later in this conference about some collaboration, database collaboration in India, inspired by a good guy from Belgium, who was actually inspired from us from Denmark. So it's a big advantage if we copy these variables to other parts of the world, because then we can do scientific collaborations. This is how it looks today. I know you cannot read the details, but you can just have an impression that it's quite simple. You just press some different, you make some choices on the online form. This is for inguinal hernias and similar ones, but of course other variables for the ventral hernia database. Quite easy. We have from the database more than 120 publications now, numerous PhD theses, and also 3 of these Doctor of Medical Science theses. It's the highest academic level, corresponding to about a double PhD, so to speak. So we have withdrawn taken many data out of the databases for scientific purposes and also to improve patient care. So I will show you now a few results. First of all, from groin hernias. This is publication number 4 from the database. It's very, very early study, published in 2001. And you can see here already from the first few patients that it was shown that when operating for a primary inguinal hernia, then the reoperation rate is highest for suture repair compared to laparoscopic and Liechtenstein repair. So the take-home message here, that is to, at least in our hands, to leave the simple sutured repair. And when operating on a recurrent hernia, it's the same pattern. Sutured repair is a no-go for these procedures, at least in the hands of the Danish surgeons. It can be different other places, of course. Then an interesting finding many years later was that even though we have a public healthcare system where the patient is actually kind of bound to the same hospital, then when we look at the database, actually 26% they went to a different hospital to get their recurrence repair. I understand why, of course, because it didn't work out the first time. But it's interesting because when you go to the literature and read these single center series where they say that, hey, my patient, it went so good, so well, I have no recurrences and so on, then maybe some of the patients went to another clinic to have the recurrent hernia done. There's just a word of caution. Okay, then we move to femoral hernias. This shows you the reoperation rates for laparoscopic versus open repair of femoral hernias on a country level. You can see that the open repairs had a higher reoperation rate for recurrence compared to the laparoscopic repairs. And what is behind these numbers? This is, sorry about the little confusing slide maybe, but it shows during these early years down here that we had quite a lot of these plug repairs for femoral hernias. But many of these patients, they were reoperated because of chronic pain because of the plug. We removed the plugs and did another procedure. So we have left the plug technique totally now. I think almost no patients in our country get a plug repair for a femoral hernia. And what is increasing here, that's the laparoscopic repair. And since 2011, it has increased tremendously. And you can see here what happens up to almost now, that the blue one, the laparoscopic curve here, is almost 200%. So almost all femoral hernias on a national level is repaired by laparoscopy. So if you look at groin hernias in general, you can see on this slide that this is again, this is the amount of procedures, and the Liechtenstein repair increased from about 30 or 35% when we started to very high levels. And the open sutured repairs, other open mesh, all the my way techniques, not Mac way, but my way, that decreased tremendously, and laparoscopy increased a little bit. And then what has happened since then? This is a continuation of the first graph, and you can see that actually the Liechtenstein repairs they have decreased, and the laparoscopy has increased. And today, laparoscopic repair is almost 85% of the procedures for groin hernias. There's also a downside to this, because some of our young surgeons, they are not very good at the simple open Liechtenstein repair. There's an educational issue there that we haven't solved that yet, and of course we need to have surgeons in every department who can do an open repair, of course, that for sure. So we need to discuss that. Okay. Other indicators of a quality improvement by the simple fact that you have a database, that you have this data collection collaboration is seen here. You can see in the start of the period with the database, we had higher reoperations for recurrence compared to later and later. So recurrences decreased, and it's also shown on this graph that the operations for recurrence has decreased through the years. So we tend to believe that this is a sign of having less recurrences with this increased focus on quality, surgical technique, and education also, of course. Then what about type of anesthesia? In the beginning, we had this goal of reducing the amount of regional anesthesia and try to increase the use of local anesthesia. And the reason for that is shown in this study down here, that local anesthesia for open groin hernia repair had the lowest risk of urological complications. Later need for a urinary catheter in the recovery unit, need for a prostate resection at a later stage, and actually also death because of these urological intervention. So local anesthesia seems to be best. But look here what happened. We have only managed to increase it a little bit, but most still gets general anesthesia. And why? I think the answer is quite simple, because as surgeons, we prefer that. You can just ask yourself, what would you prefer? To be honest, I think it's much easier to do a hernia repair in general than in local anesthesia. And I think this is the simple reason why we cannot increase local anesthesia more. And other findings are shown here, that if we compare high volume with low volume departments, you can see that reoperation rates for recurrence are higher in the low volume departments compared to the high volume departments. It seems natural, of course, but we didn't know that for sure until these graphs came out. And what about private versus public hospitals? It's the same pattern. The public hospitals had higher reoperation rates than the private ones. And why is that? I think it's very easy to explain, because who are the surgeons in the private hospitals? They tend to be more experienced than in general in the public sector, at least where I come from. So this, I think, it's a result of surgical expertise. Okay, then I jump to ventral hernias, just showing you a few results. This study came out some years ago, and it was about the smallest umbilical and epigastric hernias, and you can see that the recurrence rate for sutured repair without a mesh was about 20% and 10% for a mesh repair. These are quite high numbers for simple surgery, just simple umbilical hernia repair. Just think about it, 20% recurrence rate. These were all seen in person. It's not reoperation rates, it's actual recurrence rates. So it's 20% recurrence rates for simple umbilical hernia. I think it's unacceptable, to be honest. Of course, 80% are happy, but 20% is still too much. And we cannot get rid of it by using a mesh, only reduce it to 10%. So there are some work here to be done to make it better. If we go to incisional hernias, which are a little more challenging, of course, then you can see to the left that, again, the sutured repairs had a much higher risk of reoperation for recurrence compared to the open mesh repairs. And on the right side, you can see the graph about laparoscopic repairs, how to, the intraperitoneal IPOM technique has actually a quite high reoperation rate for recurrence compared to simple onlay and sublay techniques, the open procedures. So again, it shows you that the rates of reoperation are too high. We still have room for improvement here. I cannot tell you the final solution, but we have some more work to do in this area. Incisional hernia is a challenge. Then there was some discussion before about absorbable tags or permanent tags or no tags in laparoscopic inguinal hernia repair. I can show you results from laparoscopic incisional hernias. And I'm sorry for the graph because it's the opposite way. This actually shows the recurrence-free survival, which is a crazy term. It's not as before the graph said before. So this means that absorbable tags has lower survival. It's not patient survival, it's hernia survival. So it shows you that there are more recurrences with absorbable tags compared to non-absorbable tags in laparoscopic incisional hernia repair, and no difference in chronic pain. Can you remember years ago when the companies wanted us all to switch to absorbable tags? The main argument, at least where I come from, was that it gives less chronic pain. That's not true. The same amount of chronic pain, even so the amount of recurrences are even higher. So it's not advisable. Maybe we should change to a totally different surgical techniques. I'm more in favor of that opinion nowadays, but we can discuss it. Another issue is that we had to give feedback to the surgeons. We have our annual reports with nationwide results, but also results from the single department. We have not results for the single surgeon, even though we could give that, but we are not allowed to at the moment because of crazy law, but I hope we can solve that. We also have annual meetings where we discuss all the latest results and the report, and we formulate national guidelines that all the surgeons actually follow. So it's nice that they believe us so much that they follow our guidelines. These are just some of the guidelines that we have done based on the inguinal and femoral hernias, and this is incisional and parastomal hernias. You see, you can Danish now. Incisional hernias and parastomal hernias, so easy, right? You can speak Danish. Good. So, in conclusion, the Danish hernia database is actually two databases. It's the Danish inguinal hernia database and the Danish ventral hernia database. We can merge data, of course, if necessary, but it doesn't make sense. But it's two different group of variables that are registered. Another thing that is important having such a registry is that we can actually now have mesh surveillance after hernia repair. You can, of course, remember years ago where there was this fissure mesh case, and it was based, among other things, on these data showing that the risk of reoperation for recurrence was much higher with the fissure mesh compared with all the other meshes. That's for laparoscopic incisional hernias. We had a suspicion that there was a problem just from clinical experience, and then we went into the database, took all the data out, and what happened? We saw this terrible graph. And then after that, actually HSICON, they withdrew their fissure mesh from the entire world market. And that was based on data from two large independent hernia registries. The Danish and the German registry had the same findings. So that meant that the mesh is now gone. And I think it's, even though it was very nice to work with the fissure mesh as a surgeon, it was so easy to deploy and to fix, but it's good for the patients, of course. I just got this graph a few weeks ago, and it's unpublished, so it's kind of a secret still, but it just shows you that even for inguinals, there's maybe some hot news here. This is the data for TAP repair with the top 10 meshes in the country, and you can see that Ultra Pro, which is a very lightweight mesh, seems to have a much higher reoperation rate for recurrence compared to all the other meshes. We are now digging into these data, trying to look at it in detail, but I'm quite sure that there is a problem with the lightest of the lightweight meshes for TAP repair. Not for open repair and other indications, that may be absolutely fine, but for TAP repair and probably also TEP, of course, then it may be a problem to use the meshes with the lowest weight. So what lies in the future for us? We will integrate PROMS, patient-reported outcome measures. We don't have that at the moment, but we will try to integrate that in the database, you know, something about how much pain do I have, what are you doing in your daily living, quality of life, and so on and so forth. And we're working on an automatic electronic system that will mean that if the patient has an operation, then the system will automatically send them an electronic message to have these data obtained automatically after the operation. We are not there yet, but we certainly hope that it will be a reality shortly, hopefully. Then we will also increase the international collaborations. We already have very good collaborations with the Swedish registry and also some from the other countries, but as I said in the beginning, if some of you guys, if you want to copy our variable list and setup and whatever, please do so, because it's only an advantage to be able to merge data later on to have more sound conclusions. So overall, the conclusion is that if we have such a database, we can accumulate large data sets in quite short time. It's an advantage to have national registries, but it can certainly also be regional or other kind of collaborations if the patients, they don't migrate to other parts. That would be important. It allows feedback to surgeons, to hospitals, to hospital owners, and as I show you, it does mean that you can improve quality over the years, and is also a very good tool for research. And you can also find very, very rare events if you have many patients registered. And then at the end also we can actually follow new products to see what happens. In the European Union, it's now mandatory for the companies to follow their products with surveillance every year, second year, or so on. So I think our collaboration with the industry will increase, but why not also here? We'll see. So that was all I had to say. Thank you.
Yeah, we have another session coming up. Dr. H.G. Dr. Oration. Last 2 minutes, sir. Any questions?
Thank you very much for an excellent presentation. I think you can guide us because we are orphans, infants in creating a registry. You perhaps have the highest experience in doing so. The only thing I was upset was you didn't talk about your cycling in your talk.
What?
Your cycling.
Cycling. Yes, you're right. Yeah, we have a lot of bicycles in the country. A lot. Yeah.
So thank you very much for this excellent presentation.
Thank you, chairpersons. For the next session of Dr. HG Doctor Oration, we invite the chairpersons, Dr. Manish, Dr. Deepraj Bandakar, Dr. Suresh Chandra Hari, Dr. C.H. Ravinder Rao. Sirs, please come onto the dais.